Good afternoon. There are many things we could talk about for trauma resuscitation, but I thought we would start with these four. Fluid therapy, the concept of damage control resuscitation, some catheter techniques, and mechanical support. Now, it's important to remember that resuscitation is about preventing and or mitigating the consequences of shock. And this is a cartoon I created a number of years ago. If you come in and you are very ill, and we reverse this quickly, you have organ dysfunction. If we never reverse it, you die of fulminant organ failure, usually within 24 hours. If we do a medium job, we turn on the cascade that ultimately leads to multiple organ failure. And clearly what we want to do is push everything towards organ dysfunction and away from multiple organ failure or fulminant organ failure. And we do this with resuscitation, usually with fluid. Now, for years, ATLS taught us that an initial bolus of 2 liters of isotonic crystalloid was used to normalize blood pressure, and we continued fluid in non-responders, and we only used blood for the people that failed to respond. But the truth is, we've known for a long time that raising blood pressure to normal is not the world's best idea. It displaces the hemostatic clot. It then more fluid leads to hemodilution, increased bleeding, recurrent hypotension, and you go round and round in that circle, which doesn't get you where you need to be. This is 1960 data from one of my heroes, Dr. Jerry Shafton, who examined this in an animal model of hemorrhage. And what Dr. Shafton demonstrated is that it was the pressure, not the volume, that increased hemorrhage. There are 2 randomized prospective trials on this. The first is now 25 years old. It was done in Houston, and it randomized patients with penetrating trauma and hypotension to fluid or no fluid at all. Fluid was withheld in the study group until they were transferred to the operating room. And there was a statistically significant increase in survival to getting absolutely no fluid at all. This is our randomized prospective trial. It was in blunt and penetrating trauma, and we randomized people to target blood pressure of 100 versus a target blood pressure of 70. In fact, the projected mortality in this group was 30%, but in fact ended up being about 8%. What we demonstrated was that there was no survival advantage to raising blood pressure to normal. And so we do this to prevent the so-called bloody vicious cycle of hypothermia, acidosis, and coagulopathy. It's one of the real cornerstones of resuscitation. But in fact, this coagulopathy of trauma is substantially more complicated and has to do with inflammation and genetics and the complicated relationship with coagulopathy. It's not quite as easy or as simple as we once thought. Now, we learned a lot in the late 1980s or early 1990s when there was an epidemic of penetrating injury in the streets of the United States. High velocity weapons, multiple trajectories, prolonged operative care. And this is when we really described this lethal triad, and those that survived often developed multiple organ failure. We began using damage control, and this is a picture from damage control, shock trauma style. It always looks about the same. We did that with surgery, but we soon learned that resuscitation had to be included in that as well. And so-called damage control resuscitation recognized that resuscitation techniques must be part of this. And we try to prevent coagulopathy, not to treat it. It's limited crystalloid and then early use of blood and clotting factors. And this was the original US military data that demonstrated that the closer the patients got to 1-to-1, a unit of plasma for every unit of blood, the better the survival. And so early hemostatic resuscitation is control of hemorrhage, limited crystalloid, targeted blood pressure of 80 to 100, blood products early and often, 1-to-1-to-1 is what we said, and frequent lab studies. Now, is 1-to-1 the perfect ratio? Maybe not. This is the proper data that looked at both 24-hour and 30-day mortality, looking at a unit of plasma for every unit of blood versus a unit of plasma for every 2 units of blood. And we were unable to demonstrate survival advantage. There probably was some in the subset of patients who presented with profound hypotension, but still needs work to be done here. So I think that the way we do this is we think crystalloid's bad, colloid's probably not any better. We use 1-to-1 blood to plasma early until the dust settles, and then we get a TEG and we tailor things for the specific TEG abnormalities. We enter a period of restrictive transfusions once the patient's stabilized. Now, we've demonstrated that no fluid is better than crystalloid, and we've demonstrated that early blood and plasma likely helps. But what we've never tested is whether early blood is better than no fluid at all. Most people have gone to very early blood. It's not clear what the target blood pressure should be. And there are many other hemostatic agents that likely could help us. This is intraperitoneal foam tamponade. It's just starting to be tested here, and it's a little bit like fixing a flat tire. You put the trocar in and you instill the foam, and that is designed to stop hemorrhage. And the manufacturers tell us it will peel off once you do the laparotomy. Sounds kind of fantastic, but who knows? Maybe this is the way of the future. Catheter skills have become, in my mind, really important. And ROBOA, transfemoral balloon occlusion of the aorta, was really the earliest of these techniques. This is the original 6 patients that were described by Megan Brenner, John Holcomb, Todd Rasmussen, me, several people. And you can see that A, it worked. B, this was almost always used as a bridge to something else, and that something else was often embolization. We had good proof of concept here. These are the zones, really functionally 2 zones, zone 1 in the thorax, zone 3 in the to control pelvic hemorrhage. And we began rolling out ROBOA. We are several hundred patients into our institutional series. Now, the technology has gotten so much better. These are now 7 French, though there is a 5 French catheter that is going to be available soon. And so the miniaturized versions are highly more attractive. They're easier to insert by a lot. Does it work? Yeah, it does. Above the balloon, you raise blood pressure, you increase cardiac and cerebral perfusion. And this is obviously because there is an afterload increase. But below the balloon, you pay the price because anything below the balloon develops ischemia. Does it really raise blood pressure? The available data, this a review article suggests that the answer is yes, though the evidence is not great. What is pretty clear is that the higher the occlusion and the longer the occlusion, the greater the price you pay in terms of inflammatory compounds that are released, organ failure, or the need for vasoactives. And it's not without risk. vascular complications were relatively common. You see the patient, this is the old Reboa, a 12 French catheter. And as we have miniaturized this, the complications have gotten less and less. I think that the real advantage of Reboa is in the pelvis. It achieves inflow control. You know just where to put it. There is no visceral ischemia. You can keep it inflated, in our experience, several hours without real problems. And it even helps to stop venous bleeding by limiting inflow. Now, this needs to be done in a safe place. One of my favorite slides reminding us that geography is important. This is our sort of look at the world. And I realized that interventional radiology, where most people do catheter therapy, was 1.5 city blocks from where the patients, and more importantly, we were. We built a new tower. We opened an hybrid operating room, and we actually went into the business of having our own surgeons do the endovascular cases. That's Megan Brenner and Melanie Hain. This was the first series. We started slow. It was only about 10 per month. And you see, we did all manner of endovascular care, and we had really very, very good results. Now, this has amplified. We're currently doing several hundred, some years closer to 300 endovascular cases for trauma. And what we have demonstrated is a statistically significant, highly significant decrease in the time to angioembolization for the time-sensitive issues like pelvis, liver, and extremity hemorrhage. We reduced time by over 2 hours in each subset. Now, these catheter techniques really are a bridge to mechanical support. This is data from the Vietnam War, where Peter Safar and Ron Bellamy realized that many people died instantly, but there was probably 20 or more percent that could survive if we could just get them to care in a way that made the most sense. And Dr. Safar was the person that recognized that deep hypothermia could actually accomplish that. This is animal work that shows that even with 60 minutes of cardiac arrest, if the animals were at 10 or 15 degrees, they all woke up and were neurologically normal. There is now a single center study. It is at the Shock Trauma Center in humans. We had to suspend it for COVID, but hopefully we will be up and going again soon. But this is simply one of many options. This is selective aortic arch perfusion, a very proximal balloon occluder of the aorta with a channel that allows you to put in blood or vasoactives, or even perhaps to induce deep hypothermia. And so that we really end up with this sort of arc of resuscitation that starts at global hypotension and open hemostasis, old-fashioned ways, and works its way through permissive hypotension, Reboa, aortic arch perfusion, and ultimately metabolic manipulation. And so you can just see it going in a stepwise fashion that allows us to increase the level of sophistication of the mechanical support. And products like lyophilized plasma, extracorporeal supports, slowing the metabolic rate with things other than hypothermia, all of these would be a way to extend the golden hour. Now, can it be done? Yeah, it can be done. And the way to do this, frankly, is to push it out of the hospital. This is data about taking it to the patient in the street, mobile VA ECMO in Germany 5 years ago, with a staggeringly good success rate. 50% of the people survived the discharge, and almost all had good neurologic outcome. And one of my favorite slides, this is the Louvre in Paris, with two of the providers putting the patient on VA ECMO in the museum. It's a crazy thing. But if they can do it in Germany and Paris, why not the US? Why not every place? It's a complicated thing to do, but it's certainly possible. So limited fluid early, I think, makes sense. We should not be trying to normalize blood pressure immediately. Balanced blood resuscitation is a good idea. The exact ratio has yet to be defined. Rabo is not a fad, it's here to stay. And other catheter devices will be here soon. The future is indeed bright, and I look forward to seeing where we are 10 years from now. I really want to thank you for allowing me to make some remarks. Good afternoon.